Welcome back to this lecture, and we are still having pharmacokinetics, specifically absorption, and we want to talk about the general terms that are usually used, or you'll find quite often used when we come to absorption. Now, the very first term that you will come across is what we have already defined or looked at, and that is none other than bioavailability. And now this is the measure of, of the extent to which the active drug ingredient is basically absorbed from what we refer to as the pharmaceutical form of that active ingredient, from its pharmaceutical form, and then it becomes available at the site of action. And here we basically mean the blood circulation. So in other words, we are saying how much will be available at the site of action when this particular drug has been administered. This is what we refer to as the bioavailability. Now, bioavailability can be given by formula, and as you can see, it is basically referred to as the area under the curve, or the area under curve of an oral drug divided by the area under curve of uninjected, of the injected drug. Then you multiply by 100, because bioavailability is basically a percentage. Now, there are two types of bioavailability, to be more specific. There is what we refer to as the absolute bioavailability. And here, with absolute bioavailability, it is denoted with capital letter F, and it measures the amount against what we call the IV. Yeah, so it is a measure of the bioavailability of a drug given by any other route against against the intravenous route. So in other words, we are saying that it is not being measured against anything else but the intravenous route, because we know very well that the bioavailability for intravenous route is actually 100%. So capital F would therefore be area under curve of whichever route you have given, for example, if it is oral, and then divided by the area under curve of the IV route that you have given us, then you multiply by 100. So that is what we refer to as the absolute. What makes it absolute is that we are comparing it against, the intravenous route, which we know that its bioavailability is basically 100%. And then if you have given different doses, then you ought to multiply the different doses, as you can see in that formula there. Now we have what we refer to as the relative bioavailability. And with relative bioavailability, it is denoted by small letter f, small letter f, and it is basically you have two formulations, and you're comparing them, but they have to be given by the same route, by the same route. So in this particular context, they are comparing a syrup or a solution and and a capsule. So, and as you can see, the relative bioavailability in this particular context will be the area under curve of that drug A divided by the area under curve of that drug B. Drug A is one that has that inner curve. So the drug A is actually the capsule, and then the drug B is the solution. So that's basically how you determine what we refer to as the relative bioavailability. bioavailability. So the point to take home here is that you're having the same rate, but you're comparing two different formulations, yeah, to determine the bioavailability. So you're determining one against the other. That's what we refer to as the relative bioavailability. Now, the other term that you'll find quite often used in absorption is what we refer to as the first pass metabolism, or referred to as the first pass clearance. Now, by this, it is strictly common for those drugs that are absorbed along the GIT, because these drugs, when they are absorbed along the GIT, they have a common blood vessel where they will go to. Yeah. So once absorbed by the GIT, whatever has been absorbed will go to the liver through what we call the hepatic portal vein, through what we refer to as the hepatic portal vein. But remember, the liver is a major source of metabolism. Yeah. So if this drug that has been given along the GIT route or enterally eventually ends up within the liver, some of it might be metabolized before it even reaches the systemic circulation. Now, that effect of the drug being first metabolized in the liver before it goes to the systemic circulation is what we refer to as the first pass effect, or the first pass metabolism of this drug. And this is entirely only applies to enterically, the enteric route of drug administration. And as you can see, we see that in this example, originally 100 milligrams of a dose was given, but incidentally 80 milligrams were absorbed. Yeah, they were absorbed into the bloodstream, and once that was absorbed, once the 80 milligrams were absorbed, we know that the liver has what we call the hepatic extraction ratio of 0.5. So that necessarily means that out of the 80 milligrams that were absorbed, we are only realizing 20, because 60% is extracted or is metabolized before it reaches its systemic circulation by the liver. So essentially, you have only 20 milligrams going to the systemic circulation, where it will be required to do whatever it will be required to. But we see that first pass metabolism may not necessarily deal with extraction, but as we shall see along pharmacokinetics in the metabolism under metabolism, is that some of the purposes of metabolism is actually to render a drug active. So some of these drugs are manufactured as prodrugs, and then when they eventually go to the liver, then they end up being activated. So it's not so much about the extraction. However, for the first pass metabolism or first pass effect, we look, or we point more into that area of extracting or destroying the active part of some of this drug, so that eventually you have less of the amount of the drug going to systemic circulation. Now, that is what we refer to as the first pass metabolism. Now, the other term that you'll find quite often used is what we refer to as the bioequivalence. And in here, it's basically a clinical definition referring to two formulations of a drug with similar extent and rate of absorption, that there is likely not to be any clinically important difference. So in other words, we are saying that two drugs are basically bioequivalent if the extents and the rates of absorption are the same. And so there is no clinically important difference between these two drugs. And as you can see, it is very well illustrated on the chart there, that the two drugs almost follow the same curve. That necessarily shows us that, these drugs are having almost the same extent and rate of absorption. So two drugs are said to be bioequivalent if the extents and rates of their absorption are the same, that there is necessarily no clinically important difference between the two. And then the other term that you'll find quite often used as far as absorption is concerned is what we refer to as the therapeutic equivalence. Now this is very important, and for two formulations they are said to be therapeutically equivalent if they are actually bioequivalent, and then they are said to be therapeutic equivalent, or they are said to be having the same therapeutic equivalence if they do not have any impurities, or even they have the same amount of what we call the active moiety or the active ingredient. So basically those are the terms, the common terms that you will find used. And as we said earlier, we started with bioavailability. Of course, we defined it, and then we said that there are two forms or two types of bioavailability. We have what we call the absolute, which we compare against the IV route, and then we talked about the relative. Here we are basically comparing two formulations that are given by the same route. And then we said, or we talked about what we refer to as bioequivalence, and then finally therapeutic equivalence. Now those are the terms that you'll find quite often used as far as absorption is concerned. Now that, with a series of those lectures that we have seen earlier, that marks the end of our absorption, which is part of pharmacokinetics. When we come back next time, we shall now look at drug distribution.